Okay, today we are going to talk about an extremely common problem, insomnia, and is worry the problem? I'm Dr. Martin Rutherford. I am a certified functional medicine practitioner. I am a chiropractor since 1979.
Dr. Reno Gates, board certified chiropractic neurologist, also a chiropractor.
And we have a chronic pain practice, more or less, more than less. And these are two separate disciplines that we have married in order to come up with some consistent solutions, some long-term solutions to these types of problems. And in many of these chronic pain cases, both disciplines seem to be necessary. We get a lot of folks that come in here for problems of fibromyalgia, peripheral neuropathy, dizziness, vertigo, balance, restless leg syndrome, which we're going to touch on here today. But not that many come in for insomnia or come in for restless leg syndrome, but many, a substantial portion of the patients that we see with these other conditions have insomnia. Mm-hmm. And it's usually a real it's a significant point of reference in the initial histories, in the initial consultations, because when you have some of the things that are causing insomnia, and these are the same neurological mechanisms that may be causing and or perpetuating many of your other chronic conditions. Would it be fair to say that?
It is fair to say.
Okay, so today the overview of today's broadcast is we're going to be looking at sleep apnea, restless leg syndrome, and other parasomnias, and why 50% of the population suffers with insomnia. 50%, that's all. It seems more because of our patient population. Neurological mechanisms involved with insomnia. This may surprise some of you and not surprise other of you, that your brain may be the problem, and natural solutions. So stay tuned if any of those things sound interesting to you. So do you want to kind of review that overview in any way, shape, or form?
No, I think
or do we just want to go on to, we have a patient that come in. Essentially, our average patient comes in, they have difficulty falling asleep, feel like their brain's going a million miles an hour. They wake up in the middle of the night. They have difficulty falling back to sleep after they wake up. Maybe some people stop breathing while they're sleeping.
No, absolutely. So that's a great place to start. So first we should define insomnia, which isn't in our outline. In essence, insomnia is defined as either you can't fall asleep, you can't stay asleep, or you wake up too early and you're just wide awake. And then you have excessive daytime sleepiness. Okay. That's insomnia. And that's basically in the absence of these other conditions we're going to talk about. So you need to exclude these other diagnostic possibilities, including obstructive sleep apnea. With sleep apnea, there can be an obstructive component. Sometimes people just have too much weight in terms of mass in their neck. I think you know what we're talking about.
I want to define sleep apnea.
Sleep apnea is basically where you're sleeping and you stop breathing. That's the simple explanation of it. And it can be quantified rather acutely with sleep studies. We refer patients for those, and they'll basically see that you stop breathing for certain lengths of time. And if it's so many times every hour, then you are diagnosed with sleep apnea, and they're going to put you on a CPAP or a BiPAP, which is basically air pressure going into your mouth. And it was interesting. I was reading one neurology journal over this weekend on the subject, and they said exactly what we've seen to be clinically true. They say, well, it's so important to get these people on CPAPs and BiPAPs to get that airway pressure into their mouth so they're not gasping for air in the middle of the night, which can be really hard on their heart. But they said, inevitably in a couple of years, everybody stops wearing them, wearing the mask, right, because it's so uncomfortable. And we've heard that story from patient after patient after patient who's diagnosed with sleep apnea. They know they need to wear the mask, but they stop wearing the mask because it's a nuisance and it's very uncomfortable. So that's sleep apnea. Now there can also be neurogenic sleep apnea, and that's where when we go to sleep, basically think of your musculature is shutting off, and muscle tone is really shut off when you're in REM sleep. most people know REM. It's called rapid eye movement sleep. So your eyes will be darting back and forth, but basically your body is paralyzed, and people will frequently dream in that state. Now, we also dream in non-REM sleep too, just so you know. But a lot of times people remember their dreams, and their dreams can be rather vivid from REM sleep. And they feel paralyzed sometimes in those dreams because their body literally is paralyzed. But you can become paralyzed so much so that you lose airway pressure through your trachea, because basically your throat collapses because you lose so much muscle tone in your neck. So that's neurogenic sleep apnea.
So that would be the REM, rapid eye movement behavioral.
That's a little different. And so in evaluating an insomniac, you have to make sure they don't have sleep apnea. One other thing that you want to ensure that they don't have is something called rapid eye movement behavioral disorder, which is seen with conditions like Parkinson's. And Parkinson's patients, unfortunately, sometimes when they're in REM, they can get hyper aroused. And so they'll get up and they'll walk around and they'll have limbs flailing and they'll do bizarre things. It's more, I'm not going to say that, but I was going to say it's more common in women. I can't assert that. But that's rapid eye movement behavioral disorder. Also tying in with this can be restless leg syndrome. So some people just have difficulty sleeping because their legs, they'll have this feeling that they need to move their legs when they're trying to go to sleep, or they'll have periodic limb movement disorder of sleep, where when they're asleep, their legs will be thrashing and writhing, and that can wake them up. So those are movement disorders, what we just talked about.
So those are not insomnia.
They're not
Those
insomnia.
are separate. And the patient would pursue that how? They would go to a neurologist?
Probably a neurologist, or go to your GP and they'll refer you for a sleep study. And in a sleep study, they'll see all of this.
So if you're having insomnia and it's not getting better and you have any of these things and you haven't been sent to someone to evaluate those, then that's something that you might consider doing. Mm-hmm. Yeah. So,
and the last being narcolepsy. So narcolepsy patients, in essence, they're going throughout their daily activities and they'll fall asleep pretty much right away. And they'll go into what we term cataplexy. So they'll basically paralyzed, and then they'll wake up. But lots of times they'll have unrestful sleep during the night, but they'll have excessive daytime sleepiness to the point of where they're non-functional. They can fall asleep at the wheel. And with narcolepsy, what we're finding is that there is a huge correlation between narcolepsy and autoimmune disorders. So they're finding that it's really an autoimmune problem in the brain that's causing narcolepsy.
And we've seen that.
Mm-hmm. We have seen that. We've seen improvements with that. And we've talked to many other patients who maybe change their diet, they restrict food immune reactivity, so foods that they were intolerant to, and they feel better in terms of their narcolepsy. Yeah. So it's pretty interesting.
So most of the patients who come in, again, they don't come in with these things, or they come in with these things, these conditions, but they're not coming in for them. They're coming in for one of the other conditions, a fibro or something along the lines. And it's more common than not that the patient has already pursued a medical route. It's totally understandable. It's something that's more common out there, but when you're not sleeping, as Dr. Gates said, you're not thinking during the day. You could be falling asleep at the wheel. You're not performing your job. You're not having fun. You're falling asleep, and so on and so forth. And so the medical approach is a little bit more pathological. In other words, pathological meaning using something that's going to affect immediate chemistry and hopefully cause an immediate change in a specific medications. Mm-hmm. So you want to discuss maybe some of the medications that and the nuances of them that are being used in insomnia.
For sure.
In true insomnia.
Because lots of times when patients have insomnia, they'll go to their general practitioner. General practitioner will ask them, well, what's going on in your life? There's a frequent report of high levels of stress. So there's some life event going on that's causing that person maybe not to be able to sleep. They got 4 kids, they're working 2 jobs, or they're having some sort of a relationship issue. And so it has become common for a GP or even a neurologist at that point to say, let's try Xanax. Xanax is it's not natural. Xanax is a drug that will shut off anxiety or stress-based circuits in the brain. And Xanax can work really well for sleep.
Right.
But the problem is that Xanax, which is in this class of medications called the benzodiazepines, it binds to receptors that are called GABA receptors. And GABA is our major inhibitory brain chemical that we have. So when you take Xanax, your brain kind of shuts off. Simply think of it that way. Unfortunately, when people take benzodiazepines for sleep, they will have poor phase 4 sleep in the non-REM category. So with sleep, we have non-REM, and then we have REM. So in non-REM, there are 4 stages. And so the 4th stage gets really disrupted by taking Xanax. So a lot of people will say that they have just kind of fragmented sleep when they're taking the Xanax, or it's unrestful sleep. That's what they'll report. So the medical community addressed this issue and basically found kind of a similar way to stimulate these brain chemicals akin to Xanax, and they use a medication called Ambien, or Zolpidem is the technical name. And Zolpidem basically doesn't cause disruption of phase 4 sleep, but a lot of people report feeling groggy during the day with taking it, and so the medical community now is trying to figure out how to give you just enough Ambien so you sleep during the night, but you don't have enough of it still in your system in the morning. But we attached an article to today's broadcast. Your risk of suicide is increased when you take Ambien. They've shown that because you're affecting brain chemistry. And so while it may work, and while obviously sleeping is really important, just know that we're going to talk about the underlying mechanisms here and some possible solutions that we've come across in our patient population.
Yeah, you have to watch when you're taking medications because it affects brain chemistry. It also can then intervene in other vicious cycles and other systems of the body, and it can be a real kind of problem to trace those things down if you're trying to get somebody better of something else. And I would also add to Dr. Gates's comments on people are going through some sort of a stress, a job stress, a relationship stress. But these are also the people who come in here who are the chronic pain patients who have had a long-term, like post-traumatic stress syndrome, or they have a fight-flight syndrome that is overreactive because they've been sexually or physically or verbally abused when they were a kid the last couple of days. Some of the histories have been, I was raised by alcoholic parents. They didn't beat me, but that type of thing. Some long-term stress that may have set off your sympathetic nervous system, and now you're in kind of a mini fight-flight syndrome or mini post-traumatic stress syndrome. I find that their histories are pretty consistent with, I can't go to sleep no matter what I do. I wake up in the middle of the night, I can't go back to sleep, and of course I'm tired during the day. So the chemistry, so the medical chemistry. So look, if you don't know any better, well, I shouldn't say it that way. I guess if you don't know anything different and that's affecting your life, you would be foolish not to take a medication if it's not helping you, because certainly I've heard the testimonials of people like, I was taking Ambien, I would be crazy. I would have no life. I'd be crazy. I couldn't do this, or I couldn't do that. We're going to present to you potential other alternatives to that are many times as effective, and yet may not carry with it all the consequences of having your brain chemistry altered and having that interfere with other physiological pathways, particularly in people who have chronic pain, the fibro patients, the peripheral nerve patients, and all those types of folks that are out there. So common alternatives. This is a big one, actually, because I tie this in with in understanding chronic pain. One of the things that we had to understand was that our patients it wasn't just that they were in stress. It wasn't just that they were having a bad day or a bad relationship, but most of our patients are in more or less post-traumatic stress syndrome, some sort of chronic fight-flight. So this was a big challenge to address this for us, because in our observation, prior to addressing this, the results were less. We weren't able to get as good a results, but certainly long-term results were very sporadic, whereas now we're starting to see a much better long-term result because of Dr. Gates's effort of getting into this and working with the neurology and the chemistry and getting together some solutions that patients can do long-term that can be very helpful. So let's talk about some common alternative solutions and whatever else you want to.
Yeah, and I'll just tie in what you were saying about the medications, how they can be really helpful. We're never anti-medicine, but our prerogative is such that we want to try and hit this naturally as best as possible. Now, we've seen a lot of futility or let's say lack of value with some of these alternative supplements. So people will come in saying, I got to take my GABA every night. GABA is that inhibitory neurochemical we talked about. Well, if you take GABA and you fall asleep, you got another issue. Because GABA, you shouldn't be able to take GABA and have an effect in your brain. You should be able to take GABA and feel completely normal. But a lot of people report that it helps them to sleep. And it's only helping them to sleep because their blood-brain barrier is like Swiss cheese. And so if that's occurring, just know that you probably have underlying inflammation in your body that's breaking down your blood-brain barrier such that the GABA is able to get into your brain and have an effect.
Yeah, you have a actually separate system in your brain.
Right? Yeah, it's completely separate. You have
a completely separate immune system. And this barrier is supposed to keep everything out of your brain that's happening in your body that doesn't belong there, because clearly nature has given us the understanding that the brain is pretty important. and so, yeah, so when that barrier that's supposed to be keeping all these molecules out, and as Dr. Gates stated, GABA is a pretty big molecule, so it shouldn't be getting through that barrier. When that gets through, you're taking GABA, you have it, and it feels better. Good, it's good, you're taking it, it's good, it's helping. But you have other issues, and those issues go beyond a bad blood-brain barrier.
Yes, they do. Yeah. And maybe a more poignant example would be that the pharmaceutical industry makes a large, substantial amount of their income off of medications that work on a GABA mechanism. When we look at anxiety-based medications, to sleep medications, to medications for chronic pain, medications for neuropathic pain, all these medications are there because taking GABA by itself should not have a clinical effect.
Right. So the point is that you take GABA, you feel better, it's okay, but you should be looking beyond that. If you're an insomniac, you should be looking beyond that, because there are other things in your body that are going wrong that are not good. And this is really, really the optimum way to go about resolving your insomnia.
Exactly. So valerian's another example of people who have difficulty sleeping. They know that if they go to the natural food store, they talk to a clerk there, they'll say, oh, take valerian for sleep, it can work really good. And sometimes it does. Other people will take melatonin, and melatonin can have a good effect as well. We have found that you have to really kind of specifically find the right amount of melatonin for someone who has difficulty sleeping to start sleeping well again, in the context of everything else we do.
I was just going to say, we use all this stuff, but in the right context of everything that's going on. 5-HTP?
They haven't talked about that. Not as much for sleep, it's just more for mood. And then mindfulness, meditation, things of that nature can all be really, really great. I have a friend who teaches meditation classes. It's fantastic, but in our experience, a lot of patients who come in, they have post-traumatic stress disorder. Their life is falling apart. They don't know how to meditate. So you tell them to start meditating, and
makes them more frustrated.
It makes them more frustrated because they realize that they can't stop their thoughts. They can't stop their worry, which really takes us to kind of the point of today's broadcast.
What's actually going on?
What's actually going on. And it is excessive worry. That has been found to be the critical factor seen amongst most patients who have insomnia and don't have sleep apnea or restless leg syndrome. They have nighttime worry. And in the brain, we have a worry center. We used to refer to it with my grandma as her worry box. She'd worry about this and she'd worry about that. Put it in your worry box. Well, really what's going on neurologically is that you have a fear center in your brain called the amygdala. And across our population, we're seeing that the amygdala is involved in a lot of conditions, including depression, not only anxiety, but also insomnia. So they'll show like a fearful image to patients who don't have any difficulty sleeping, and they'll show a fearful image to patients who have difficulty sleeping, and they'll see that the amygdala just lights up in the insomniacs, whereas in a normal individual, it's just kind of like, oh, okay, no big deal. Well, that's a problem. And then they've done further studies where they're seeing that the brain and how it connects from one area to another is rather disrupted in insomniac patients. So just know your brain's connected weird when you can't sleep. And so different regions start hyperconnecting and other regions don't connect well enough. And in essence, what happens is that the fear-based responses from the amygdala cause overactivation of the brain. And as a result, then you can't sleep and you can't fall asleep. So your brain won't shut down because it's in this constant state of fight or flight.
And would it be fair to say, and this is a question I ask people, do you feel like it's you? Because they worry, they worry, but then there's a point where they do start trying a number of methods and they can't do it because they go, no matter what I do, it seems like I can't overcome it.
That's an awesome question. Yeah.
What's that?
That's a great question.
Yeah.
Yeah, that needs to be hit on.
And it's kind of like, because then people start taking it on as a personality disorder, and even though they have started to worry about something, that part of the brain is now not going to shut off. And now it's just perpetuating it. And now they're like thinking, man, I'm like really a weak person. And in essence, if you can calm that part of the brain down, then these other methods will start to work.
Right. And the reason why the amygdala...
And that can be done. That's why this is part of what we do here every day. That's why I'm mentioning it.
And we highly recommend you go back and watch our depression and anxiety broadcast, because we talked about this subject a lot. And though we're not saying those of you who have insomnia, you're all depressed and anxious, we're not saying that. But the same mechanisms are going on in your brain. And in essence, the frontal lobes, specifically the bottom part of the frontal lobes and the medial part of the frontal lobes, yeah, exactly, right through here, are critically involved in shutting off your amygdala. Also, the memory area of the brain is critically involved in shutting off the amygdala. So think of it as like a tug of war. You have the amygdala, and then you have the frontal lobes, and you have the memory area of the brain. And these two guys are trying to pull on the amygdala, but unfortunately in today's society, especially since 50% of adults report having insomnia at some point during the year, and basically upwards of 30% suffer with chronic insomnia. That's a third of our population. Our frontal lobes and our memory center are losing the tug of war with the amygdala, and it is dominating your brain. And because of that, it's not that you're a weak person, it's just that your amygdala is so strong, you can't shut it off. And so all those events from the day, once you start to lay down, you're trying to fall asleep, then your amygdala starts firing off like a firecracker and your brain won't shut off. Or you'll fall asleep, but the amygdala is firing off like a firecracker and it will wake you up, and people will say, yeah, I just woke up in the middle of the night thinking about work, or I woke up in the middle of the night and I solved this problem. Well, that's not necessarily a good thing. Right. You should be able to go to sleep and shut your brain completely off, wake up the next day feeling rested, then solve the problems. We don't want to solve problems in the
And as the dominoes fall, this may seem very mechanistic, but then as the frontal lobe starts losing the battle, and as what is it, the hippocampus, the memory center starts losing the battle, you start getting symptoms of those areas not functioning right. So frontal lobe, you might get depression, you might get anxiety. For the amygdala, is now wearing down, and now, or the hippocampus is now wearing down. So now you're getting short-term memory loss and things of that nature. And so it's this, again, it's this vicious cycle that we were referring to earlier that doesn't get handled if you're taking Xanax, right?
And that's
or
one of the main things
benzos, or if you're taking Insomnia or anything like that.
And that's one of the main things they're now talking about in the literature, is that all these insomniacs report during the day that their executive function is off. So it's just not making good decisions. Frontal lobe, they're unable to have good working memories, Dr. Rutherford said. Frontal lobe tying in with your amygdala. Their emotions become dysregulated. So that's because their frontal lobes are not modulating their emotions as well as they should. And it's fascinating because the exact areas of the brain that are losing this battle with the amygdala.
Yeah, and so then it goes beyond that, because then you're putting out a lot of chemicals that on it perpetually, that Dr. Gates is going to explain in a second here, that shouldn't be getting sent out to a lot of different parts of your body. And these create associations with the other things that we treat, like chronic pain.
Exactly. So then you can go back and watch all of our fibromyalgia broadcasts. I don't know how many we have now, 6 or 7. And
depression.
So, yeah, you watch depression, watch traumatic brain injury, because what happens is when the brain won't shut off at night and we can't repair, then as a result, we start making all these stress hormones. These stress hormones can flood throughout our body. The stress hormones can be like lighter fluid on pain nerves for the fibromyalgia patients. Also, when we don't sleep at night, the good neurochemicals we make in the brainstem that shut off pain reflexes aren't made appropriately. So it's, there's one doctor out there who's a big fibromyalgia expert, and he'll say, you can't fix a fibromyalgia patient until you get them sleeping. I don't quite agree with that, but sleep is a really important aspect to handling fibromyalgia. And frequently, if a fibromyalgia patient is not getting better when you've addressed a lot of other components of their disorder, like small fiber neuropathy, like Hashimoto's thyroiditis, like their childhood abuse, then if they're still not sleeping, then yes, you have to be absolutely attentive to that. And we've had big breakthroughs by getting fibromyalgia patients to sleep. And the same goes with depression. So is it chicken or the egg? They're saying that, a lot of depressed subjects, they wake up early or they have insomnia. Insomnia is one of the cardinal features, or hypersomnia, where people sleep too much, is one of the features of depression. And that's because this amygdala circuit is dysregulated, not only in insomnia, but that's also seen the same way in depression, just a little different. And then traumatic brain injury, what does traumatic brain injury do? We know instantly after you hit your brain, we're talking concussions, major blast injuries in war, people who get in fights, things of that nature, you immediately start to see inflammation in the memory area of the brain. And so that memory area of the brain loses its battle with the fear area of the brain, and then the fear area of the brain escapes and you can't sleep. So this is an intermingled web, and it's really, really exciting because in the first, month of this year, we've really highlighted kind of these deep areas of the brain and how they tie in with memory, how head injuries tie in with them, how they tie in with depression and anxiety, and now how they tie in with sleep. When you look at the numbers, 30% of the population has anxiety, about 16 to 20% has depression, at least 30% has chronic insomnia, and then upwards of 50% and suffers with insomnia at some point. These are major, major issues that tie in with the chronic pain epidemic, which is affecting about half of our population, or our adult population. Yeah, so 120 million Americans. So this is important.
Yeah, this stress mechanism is very important, and we do, and we work in an integrated fashion here. I'm a certified functional medicine practitioner, chiropractor. Believe it or not, being a chiropractor happens to be very helpful in figuring out a lot of these problems. Dr. Gates is a functional neurologist and a chiropractor. We also have a functional psychiatrist that we work with sometimes on these cases. We have a clinical hypnotherapist that we work with sometimes on these cases. When I say sometimes, we do pretty lengthy evaluations, and you can determine the severity of this person's brain effects on their physiology, and then you can determine whether to go into that direction. But the patient coming in who is more alternatively minded has generally already tried GABA, valerian root, meditating, and frankly, many times all of them put together, and it's not working because they probably have a bad blood-brain barrier. Just the stress hormones that are circulating from that fight-flight mechanism that amygdala is not shutting down perpetuates the problem by coming back, and those have a propensity for the memory system, right? And then that weakens that, and then it allows the other thing to get strong. It's like, I know it's just a vicious cycle. Just know that. And so, even and everybody who comes in here is on medications, and most of them are not working well. Some are working, and sometimes people just go, I just don't want to be on the medication because it's making me like I don't feel right, and I don't feel like I'm there, and things of that nature. So the point being that when we say insomnia is important, it's like incredibly important. It's almost like a one-to-one relationship with these stress mechanisms and the things that we have found in chronic conditions and chronic pain. And it doesn't matter. When I say chronic conditions, I don't care if you have restless leg syndrome or dizziness or vertigo or balance. I don't care if you have a bad gut. Whatever you got that's not going away, there's a strong probability that this is present. So you go to the doctor and you have a bad gut, and the alternative doctor gives you like 15 different pills. For this one's for H. pylori, and this one's for bacteria, and this one's to fix your gut, and you feel a little bit better, and then it doesn't come, and maybe even start sleeping a little bit better, and then suddenly you're not. And it's because the stress mechanism has been sabotaging everything the whole time. And that stress mechanism is there. You have insomnia. You're not going to be able to go to sleep. You have a difficult time waking up in the middle of the night and going back to sleep. So when we say that all of these things are intertwined, if you have insomnia and you're listening to this, I'm sure you have some of the other things that we're talking about. It would be virtually impossible not to. But we have dissected everything out today. You go to this, and also just to go back to the sleep apnea, and I will tell people a lot of times, people who have sleep apnea, maybe you've been diagnosed as having insomnia and you have sleep apnea, but we'll go through our program and the sleep apnea will go away. If they don't have obstructive sleep apnea, like I may have from a bad deviated septum, then it's the brain issue. And we have introduced brain work into virtually every case that we have now, and it has made a big difference. And even though the person hasn't come in for the insomnia, it starts to go away, or the sleep apnea, it starts to go away if it's not obstructive, because these vicious cycles are involved not just in your insomnia, but in many of the other things that you're probably experiencing. Maybe all of the other things that you're probably experiencing. I'm not just saying that. I mean, this is what we see all the time. So what do we do for insomnia? They're not like, so what do you do?
Well, as an example, I read something new this morning. We always knew that the frontal lobe is involved with depression. We knew that the frontal lobe can lose its size. Read a new statistic that they're finding that you can lose upwards of 40% of your frontal lobe density down at the bottom in the medial portion with depression. That is staggering. 40%, that's almost half of your frontal lobe density down there. Because as Dr. Rutherford was saying, when these stress circuits start firing, these stress hormones fire, they specifically cause lack of neuronal growth, or not that you're growing new neurons in your frontal lobe as much, but basically your frontal lobes neurons don't repair themselves. Also, we know that the memory area of the brain, which does have a tendency to grow new neurons, that will stop in the presence of stress hormones. So what you have to do is you have to step back and look at the person functionally, which is, it's a hard term, because within all those articles that were attached to today's broadcast, everybody wants to be so narrow-minded. Okay, this is insomnia. This is what happens with depression. This is what happens with anxiety. What we're seeing from a functional perspective is that the same brain circuits are really involved with all these disorders. There are just some nuances that may result in one individual having depression. It could be very complicated versus one individual having anxiety. So we have to step back and we have to look at that individual and figure out what areas of their brain are not working. Do you have a bad frontal lobe issue? What part of your frontal lobe is not involved? Do you have a cerebellar problem? Because the cerebellum talks to the opposite frontal lobe 12 to 14 times a second.
I was going to say that, but I didn't want to make you look bad. You say you missed the cerebellum. I have a bad cerebellum, so I would be aware of that.
And so
yes, I have everything.
We want to look at those features. We also want to look at, okay, what is this individual's life like? Were they exposed to childhood trauma? Do they need to go see our clinical hypnotherapist? Do they need to go see the psychiatrist, who is probably one of the top psychiatrists in this country, but also he has immersed himself in functional medicine and trying to figure out the other nutritional and biochemical aspects as to why somebody would have depression. And so we look at those features. And then we also look at your present life. Are you really stressed out? Is this something that's going to be able to be modulated by getting your frontal lobe stronger and giving you basically exercises to do at home to calm down your stress responses? Or do you need some chemicals, natural hopefully, that are going to get your frontal lobes working better or able to shut off that amygdala? And we look at all those pieces, and then we look at how your brain is interacting with your adrenal glands, because what we find is that patients frequently with this type of problem, from depression, anxiety, and insomnia, they make too many stress hormones that just keep pouring out, and their brain doesn't shut off these stress hormones. So we can work with the adrenal glands specifically to calm that down to get somebody sleeping better.
For those of you who may not realize that the adrenal glands put out those stress hormones, the brain sends the signal, the adrenal glands, which sit on top of your kidney, put these hormones out. And when that happens, lots of bad things happen to your blood sugar and to your sex hormones. And that's a whole nother thing, but I'm just trying to draw the concept of how comprehensive insomnia really is.
So you may have a genetic factor affecting your frontal lobe and anxiety. You may have inflammation in your body that's affecting your frontal lobes. You may have obesity, and the obesity chemicals, the fat chemicals are affecting your frontal lobes. You may have female hormone problems or male hormone problems, so where you don't have enough testosterone as a guy or your estrogen levels are not appropriate as a female. You may have other factors such as you're drinking a lot of coffee every day that can affect your frontal lobes. All these different things have to be piecemealed out and teased out to say, okay, we got to eliminate these variables. You may have inflammation from your gut affecting your frontal lobes. Once those factors are teased out and eliminated, then we can see actually how someone is sleeping.
Yeah.
And then if they're still not sleeping, then we strengthen the frontal lobes. If that still doesn't work, then we look at, okay, what can we do supplement wise to help somebody sleep? And then if that's still not working, then yeah, we'll refer you for a medication. Because bottom line is you got to sleep. You got to get out of that stress response. And we've had patients going through this program where, you know, they're going through a divorce, or, you know, they just lost their business. And I can tell you, you can take melatonin until the cows come home in large doses, and it's not going to help them.
Yeah, we have a gal right now who's struggling with quitting her job because she's got early on, she's doing very well. She came in for Lyme and fibromyalgia and a bunch of other things, and she's doing very well. But she's cognited that she does a lot better on the weekends. And she feels a lot better on weekends. She goes back. I'm not going to say what job it is, because then people will know who she is around here maybe. But she works with like a really cool job in a lot of ways, but a very, 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 very stressful job. And she's just like, you know, I think I'm going to have to quit my job because my health is more important than that. You're in a divisive relationship. We certainly don't advise. It's usually women who are on the bad end of it that are in here. We don't advise you to go home and divorce your husband. That doesn't mean you don't need to go home and divorce your husband. We just don't want somebody showing up here with a shotgun. He told my wife to divorce me, but I say that because, you know, I don't know if we only go through this planet once, okay? But we only go through it once that we're for sure of. That's for sure. And to spend the entire time being sick and having bad memory and not being able to sleep and having a bad gut and having pain and all that type of stuff seems like kind of a waste, you know. And I know we have certain parameters and certain belief systems on our jobs and things of that nature, but sometimes you have to do what you have to do to get away from that stress. If it's a stress that you can work with a lot of times when you get the frontal lobe and the cerebellum and the amygdala working right, it's amazing. Your brain starts being able to handle stress, and then you're okay. But when that's not the case, that's when we start looking at these other issues. That's when we start looking at the clinical hypnotherapist. That's when we start looking at the functional psychiatrist, because somehow you got to now learn how to deal with that stress. And then ultimately, if that doesn't work, you may have to learn to eliminate that stress. And it's a very important thing. It's hard to say that, and you don't want to say that. It's sad to say that. And it's not that you're weak. It's just that, like, if you're trying to handle this 24 hours a day, there's something that is putting you in fear. That something has to go. And so I mean, I'm just trying to draw you the gradient of complexities of addressing this problem. Insomnia in and of itself is a bad thing. When you don't sleep, I wrote a book called Power Health years ago. Don't look it up. Don't buy it. It's a simple book. But I talk about sleep in there in general and all of the bad things that happen when you don't get into REM sleep. And there's a lot of them, but it's even more important than that, because we didn't have this data when I wrote that book. And it is, if you're having insomnia and you have chronic pain and you have chronic conditions, it's a part of that vicious cycle almost all the time. So what? So if you're an insomniac and you've tried all this stuff, then you've tried the medications, and you've tried the valerian root, and you've tried the melatonin and these things, then you need to kind of like find somebody or something, or you need to start looking in the area of what we just got done talking about, some sort of protocols, or some doctor who understands this. This is what we do, those types of things. So I don't know. That's a tough one.
And I would go back and really watch the depression and anxiety broadcast, because we talked about a lot of the factors that really affect the frontal lobes there. We piecemealed it out. That way you can get a better understanding of what we're trying to say. I don't have another hour to summarize what we said there. Right. And so look at those pieces, say, okay, do I have any of these components? And, we're not telling you to do this, but people are watching these videos to get answers, and see if any of those apply to you, and see that they may be affecting your frontal lobes and your memory area of your brain, causing your amygdala to overfire. and therefore then you'll have a better idea of what to do.
Okay. So that's it. That kind of wraps it up. I think we've covered this pretty well and from a variety of different angles. I hope it helps you just a lot of times just understanding what you're going through helps to calm that down a little bit. And hopefully we've been able to achieve at least that. So we will attempt to come up with an interesting subject for next week. Again, we hope this was interesting. And if you want any more information about us, you can look us up on powerhealthtalk.com. And if you want to if you have any topics that you're interested in that you think might be interest to other people, let us know. And if it's something that we're conversing in, we'll be happy to do it. Okay.
Awesome.
See you next week.
Thanks for watching.